Okay, here we are for part 2 for respiratory mechanics. So we just looked at how we actually can get air in and out of our lungs by manipulating the volume of our thoracic cavity, which changes pressure relative to the atmosphere. And so now we're going to look at resistance to things that cause resistance to our airways, right? So the primary resistance to airflow is similar to what we saw in the cardiovascular system. It's the radius, but now it's the radius of the bronchioles, the smallest tubes at the end of the bronchi. Those are the smallest tubes that bring air right into our alveoli. And those bronchioles have smooth muscle layer around them, right? And so that's what this red is depicting here. This tube, this red, is looking like a nice relaxed bronchiole here. So when the smooth muscle is relaxed, that means the opening in the middle is more open. Remember, a space inside of any tube, we call it a lumen in physiology. Okay, and so with more space, you get less resistance and more airflow. Same thing that you learned in the blood, except there we were talking about fluid flow, blood flow. Right here it's airflow, but it's the same thing. And so there are times when you're, again, at restful breathing, your autonomic nervous system will kick in and it will actually constrict your bronchioles slightly because we need less air. We don't need as much air. So this can then cause more resistance to airflow and less air will come into the lungs. Okay, when we're really working out, we're really needs airflow, then our bronchioles will dilate and will allow more air to come in. Okay, but this has implications in certain diseases like COPD, chronic obstructive pulmonary disease, and that's when you get this abnormally resistance, increased airway resistance. So here you can see a nice healthy bronchiole on the left side, and this bronchiole is actually collapsed down. I think this one was actually taken from an example of a patient with asthma. And so you can see that with asthma, the smooth muscle will constrict, and that will really constrict down the lumen of the bronchiole, and so a lot less air is getting in. So that causes resistance, a lot less air is getting in. And really, in COPD in different forms, expiration is more difficult than inspiration. Okay, but so usually when I say that, people who do suffer from asthma, they go, but I feel like I can't get air in. Well, think about that. Once you exhale, right, and you're only exhaling a certain amount, and you have resistance, you can't reduce the volume as much, right, because that air is not pushing out. So the volume is already larger, okay, then it's going to be harder to make it even larger to get air in, right? And then the next time you exhale, so it only comes up a little bit more, you're not getting as much air in, you exhale again, and you're still not decreasing the volume very much. So again, because of that, that's going to have effects on the next inhalation. So yeah, you feel, your brain says, I'm having a problem getting air in. That's because you're having a problem getting air out. Okay, and here are other diseases like chronic bronchitis. You can have an inflammation on the inside causing that. That could be due to bacteria infections and things like that. That often is what happens, like when you get the flu, which is viral. They say you shouldn't take antibiotics when you get the flu, and you shouldn't. But if you don't get the symptoms of the flu taken care of, that can decrease your immunity, and that can actually then cause a secondary bacterial infection in your lungs. That's when the doctor may prescribe an antibiotic in order to get that bacteria out, and then your lungs can repair themselves, your bronchioles can repair themselves. Emphysema, usually an emphysema, it's more about destroying the alveolar tissue. And so if there's fewer alveoli, if they break, right, then what you're doing is these small little bubbles of air. We said that increases surface area because you have more tissue surrounding it for gas exchange to take place. But if those break, they open up to each other. So now you have a bigger space But again, there's less surface area. So there might be able to get more air in there, but you have less chance of gas exchange to occur. Okay, so emphysema also makes it hard even for expiration to happen. You can also, with emphysema, the bronchial can collapse, also decreasing the gas exchange. And emphysema is really popular in long-term smokers. This is actually what was the end of my grandpa back in the 90s. He was a smoker his whole life, and he ended up with emphysema. But the last 10 years of his life, he used an oxygen machine. He had to breathe off of oxygen because cigarette smoking stimulates those macrophages in the lungs and also leukocytes, and they end up secreting protein digesting enzymes, and they digest the tissue, the alveolar tissue. So smoke, please don't think, well, then vaping's safe. It isn't safe. There's other things going on there. That's for another lecture. All right, that's my public health announcement. It's all tied to physiology, folks. Okay, but what are some things that affect lung health, that affect tissue health, or affect the what's going to change our resistance? Oh, hang on a second. I'm going to have to pause this for a second. Okay, so what I was saying was, so indicators of lung health, one of the main things we look at is compliance. Okay, and so compliance has to do with the effort it takes to stretch your lungs, or we call that distension, to distend your lungs. So remember, we said we had to open the lung volume up in order to get air in. Okay, so when you have high compliance, there's no problem with your lungs expanding and contracting, right? But with low compliance, if you have low lung compliance, that means you have to do a lot more work to inflate your lungs. You're going to have to put a lot more energy in that muscle to pull down even harder to really pull those lungs open. Okay, so factors like, I put another disease in here, pulmonary fibrosis. That's actually what this picture is showing here. So in pulmonary fibrosis, there's actually scar tissue building up in the lungs. Things from like tuberculosis can cause that. You get scar tissue in there, and look, that thickens the tissue of the lungs compared to the normal alveoli over here. You can't see, I gotta put my laser on. Here's the normal alveoli, you can see how thin the tissue is. But here, the tissue's been thickened. So that's going to reduce compliance, making it harder to, again, stretch those lungs in order to decrease the volume inside of there, or increase the volume inside of there. Actually, the volume stays more decreased, right? Like I mentioned, other causes could be the lungs get filled with fluid, right? And so that causes a pressure on the outside here. So anything that, if there's pressure on the outside from extra fluid, that's going to make it harder to stretch the lungs. Okay, so anything that affects compliance. And so here are some effectors. Elasticity can also affect compliance. Elasticity refers to how readily the lungs rebound after being stretched, right? So compliance, stretching, but then what about the elasticity? As long as they can rebound after being stretched, then you can have compliance again, right? So that's one of the things I was mentioning with emphysema. It's hard for that elasticity to come back so that the lungs can re-stretch again the next time, right? So we do have highly elastic connective tissue in the lungs that help with that. Okay, so that's one of the tissues associated with our lungs tissue. So that's one of the factors that affects elasticity, is having good elastic tissue. The other one is what's referred to as alveolar surface tension. Okay, so surface tension, so remember we said that our lungs have all this fluid along the outside of them. Okay, there's that pleural fluid that's all around the outside in that little space. So that means fluid, and mainly water, is coating the outside of the alveoli. So one thing to remember is that from general biology, remember that one of the things with water, because it hydrogen bonds between water molecules, remember that hydrogen bonding called a surface tension. Okay, so there's surface tension in between water molecules, and it's somewhat strong. You have to break surface tension in order for water to be liquid and to move around. That's the surface tension you feel when you dive into the water, but instead of going head first, you do a belly flop and you smack and it hurts. That's because you hit that surface tension, and it took a little time for all those water molecules, the hydrogen bonds, to break, so then you could just go and move right through the column of water, right? Bugs walk on top of surface tension, okay? And so surface tension, what it does is it wants to push down on the alveoli, okay? Well, when we inhale, we need to break that surface tension in order for the alveoli to be able to expand. Okay, and that would be really hard to do if we didn't have help from our type 2 alveolar cells. Remember in the beginning of the lecture, I mentioned these. Type 2 alveolar cells produce a chemical or a lubricant called surfactant. Surfactant breaks the hydrogen bonds in between water molecules for you. Okay, and that way your alveoli, when it breaks those bonds, can easily expand, right? Easily expand and then easily go back to their regular size. Okay, so even if there's fluid on the inside, right, they're going to easily go back to their regular size. This is what happens when there's a prematurely born baby. They have a problem with breathing. They go into what's called newborn respiratory distress syndrome. What that is that we don't start to develop these type 2 surfactant cells until about the 8th into the 9th month of pregnancy. So when you have a baby that's born prematurely, they haven't developed these cells, so they don't have the surfactant. So that makes it very difficult for them to inhale. And so therefore, they have to use their diaphragm muscles even harder, right? And their external intercostal muscles, and they get fatigued really easily because they're just little babies. But the good thing is we make an artificial surfactant. It's a spray that can go down the throat. And so our wonderful nurses will come in and help those babies daily so that to keep their breathing going. Because the good thing is give them some time. The type 2 cells will start to develop even outside of the womb. And then pretty soon the babies are able to breathe pretty easily. Okay. So that is what our surfactant cells are for, to help us with the surface tension so that we can bring air into our lungs much more easily. Okay. And that brings us to the work of breathing. So normally, just normal restful breathing takes about 3% of the total energy. So just to breathe, don't you get tired? I'm just sitting here breathing. I'm using 3% of my energy. So that can get you pretty tired. I'm just kidding. Anyway, and then during normal restful breathing, your lungs are operating at about half full. When you're increase the work that you're breathing, again, you do that when your pulmonary compliance is decreased. So we mentioned some of the diseases with that. The airway resistance is increased, so resistance of airflow makes it harder to breathe. So we looked at some of those diseases that do that. The elastic recoil is decreased, okay? Lungs going back to their original size easily. All of this makes or if you just need, in general, a need for increased ventilation, if you're exercising or something like that, of course, then we'll be working harder, because I mentioned those other muscles that we engage. So more muscle means more ATP. So those can get fatigued too. Okay, so we can measure lung volumes and capacities. And so this is a measure of how healthy your lungs might be. We use a device called the spirometer. And this is a spirometer. It actually has different tubes in here surrounded by fluid. There's water in there. And so what happens by putting this device in your mouth and inhaling and exhaling, you can see it will go through different tubes. Inhale and exhale, there's a diaphragm in that kind of switches it. And what that does is it moves this floating drum up and down by the amount of air that you're actually inhaling or exhaling. And then there's a little pin that's attached to it. You can see by a pulley. So as the drum moves up and down, that moves the pin up and down. And there's this wheel of paper that's rotating around. And so it's actually producing these waves of lines that's showing you, of course, when you inhale deeper and exhale deeper, the pin's going to move more, right? Or if you're just breathing shallowly, your pin's going to move just a little bit. So that produces what's called a spirogram. And that's what this looks like. This is a spirogram labeled. And so here you can see it, normal restful breathing, follow my laser. You've got an amount, so this is in a lung volume, this is in cubic centimeters, right? And so you breathe a certain amount, inhaling goes up, exhaling goes down. So at rest, at that steady breathing, inhaling and exhaling, that's your tidal volume, okay? So that's the amount of air expired per breath in quiet breathing. Expiration, you have an inspiration. Okay, so that level here, this one shows our tidal volume. Okay. Then we can ask you to really inhale at the end of a regular restful exhale, then go inhale. When I do that, I feel my neck tense up. Again, that's the sternocleidomastoid, that's the scalene. So when I do that, I'm pulling my rib cage open even wider, increasing the volume so that the pressure goes down even more and a lot more air comes in. So this measures how much more air comes in. That's my inspiratory reserve volume. So if I do that with as big as I can get my lungs and get as much air as possible, so that they'll measure that. How much can you do that? How much can you expand your lungs? They're kind of measuring the compliance there, right? So that's the inspiratory reserve volume. Okay, and then they might say when you do that, okay, after that big inhalation, they'll go now, push as much air out as you can. Keep pushing. And you try to get as much air out as you can. So the extra air beyond what was your normal tidal volume expiration would be your expiratory reserve volume. Expiratory reserve volumes going down here. Here's showing also an expiratory reserve volume. Okay, so this was normal breathing, and they said at the end of a normal exhalation, oh, keep blowing it out. And that's what you're doing. So again, you're engaging the internal intercostals, your rectus abdominis, everything you can do to push as much air out as possible. That's expiratory reserve. So what you're doing when you're measuring from the very ends of how much you can breathe to how much you can exhale, which includes the amount of normal breathing, right? That's your vital capacity, right? So that's your vital capacity. So that includes, again, your inspiratory reserve, your tidal volume in the middle, right? And your expiratory reserve. Did I say inspiratory over there? So this whole thing, whoo, all the way down is your vital capacity. Now, remember I said you never fully collapse your lungs, right? Because of that pressure in the intrapleural membrane is always lower than the pressure in the intrapulmonary space, okay? So that extra space, because you can never completely collapse your lungs, you always have some air in your lungs. No matter how forcefully you breathe out, you never totally get all the air out, okay? And that's this extra volume here at the bottom called residual volume. That's what's left over, residual volume. So then when we add your vital capacity to your residual volume, then that's your total lung capacity. Okay. Those of you who are in lab, we're going to do an experiment like this, and I'll be testing my different lung volumes. Okay, I have a pretty good lung volume. I used to be a swimmer, so you develop some good compliance and good elasticity when you use your lungs like that. Okay, and so this table has the definition of each one of those if you like to read it. You don't have to remember the actual volume in milliliters or in the cc's. You don't have to memorize that. But I do want you to know the definition of everything in red here. The tidal volume, the inspiratory reserve volume, expiratory reserve volume, and residual volume. Okay. If you're interested in inspiratory capacity, please by all means read up on that. But anything in red is fair game on a test. And then it doesn't end there. There's a couple more: vital capacity and total lung capacity. Okay. So that's it for this lecture. Hope you guys enjoyed it, and we'll come back and we'll talk about actual gas exchange. All righty. Thank you, everybody.